Okay, I am back. Let us continue. Raise your hand if you're able to hear me clearly. All right, that's good enough. That is good enough. All right, so we're at distributive shock. We have looked at cardiogenic shock. We have looked at obstructive shocks. These are shocks that would affect the heart directly and indirectly. Now we're going to look at distributive shock. Now, distributive shock, the concept is fairly simple to grasp. With distributive shock, the issue is there is widespread dilation of the small blood vessels, and that would be the arterioles, venules, or a combination of both. So something is causing these vessels to completely dilate. So the blood vessels, these blood vessels within the body should never ever be fully dilated. They maintain a specific tone, or they constrict and dilate depending on activities within the body. If they are fully dilated, the pressure inside will drop. And that is depicted by these diagrams at the bottom of the slide. So if the blood vessel has good tone, which is the drawing depicted on the left, then the blood pressure will be adequate to supply peripheral areas and core organs within the body. But if something causes the blood vessel to open up or dilate, that's more space, more volume inside the blood vessel. That means the pressure inside of that blood vessel will drop. And that is what we call distributive shock. So distributive shock results from widespread dilation of small arterioles, small venules, or both. The circulating blood volume pools in the expanded vascular beds and tissue perfusion decreases. Now, the first one that we're going to look at, which is the most complicated one, is the septic shock. Septic shock occurs from a bacteria that enters the body tissue. So all of there are 4 types of distributive shock that you need to be familiar with. The end result is the blood vessels will be too dilated, but we need to be able to identify the cause. So with septic shock, a bacteria enters the body. The bacteria gets into the bloodstream and becomes systemic. When the bacteria enters the bloodstream and becomes systemic, it ends up all over the body because the blood is circulating the bacteria. The body is going to initiate immune response or inflammatory response. So the blood vessels that are leading to various areas of the body, which include peripheral and central areas of the body, are going to become more permeable and they are going to dilate. Also, the bacteria is going to cause small pockets to form in the blood vessels, the tiny blood vessels. The body is going to try and restrict the growth of the bacteria by increasing the temperature inside of the body. So the patient is going to develop a fever. Just keep in mind that your geriatric population can have an infection without a fever because their temperature regulation system doesn't work very well because of aging. Now, when the blood vessels start to become more permeable and dilate, we start to get massive, widespread vasodilation. So the blood vessels feeding the core organs dilate, and the blood vessels feeding the peripheral area are also dilated. So this causes a massive drop in the pressure inside of these vessels. And this is what is referred to as septic shock. So septic shock occurs as a result of severe infections in which toxins are generated by bacteria or by infected body tissues. The toxins damage vessel walls and cause increased cellular permeability, and the vessel walls leak and are unable to contract. So there is a distribution problem. The widespread dilation of the vessels in combination with plasma loss through the vessel walls results in septic shock. All right, so that's septic shock. Neurogenic shock now. Neurogenic shock is the only, well, neurogenic shock is the shock within the body that differs from all the other shocks. So it is completely different from the other shocks in the body. So pay close attention to this one, because it doesn't present with typical signs and symptoms. Now, what neurogenic shock is, the patient has a complication common with spinal injury. It doesn't have to be a spinal injury, but it's common. So let's use the spinal injury as an example. Patient has a spinal injury, but the location of the spinal injury is at an area within the spinal cord where sympathetic stimulation is created. So it's at a point within the spinal cord in which the sympathetic stimulation is created, and this is the sympathetic stimulation controls the tone of the blood vessels, and it controls the release of epinephrine and norepinephrine. Now, if the blood vessels are not being stimulated, they are going to open up completely. So you start to get widespread vasodilation in the peripheral areas of the body and the core areas of the body. Now, because there is no sympathetic stimulation, or there is little, this is a patient in which you will not see tachycardia. So you will not typically see tachycardia in this patient. And if you see tachycardia, it will not be present for a very long time. It's going to be there for a short period of time because the sympathetic stimulation is cut off. You will not see cool, clammy skin in this patient. You're going to see warm skin in this patient. Again, there is no sympathetic stimulation, so there is no peripheral vasoconstriction occurring. So the presentation is very unique with this patient. So you're looking for bradycardia, you're looking for skin that is warm, dry. You're not looking for cool, clammy skin in these patients. And that is neurogenic shock. So it's a spinal injury that cuts off sympathetic stimulation and stimulation to the capillary sphincters, which cause widespread vasodilation. The loss of sympathetic stimulation means there will be limited sympathetic signs and symptoms present, if any at all. Now, causes include brain conditions, tumors, pressure on the spinal cord, spina bifida. Neurogenic shock, muscles in the blood vessel walls are cut off from the nerve impulses that cause them to contract. And that will result in widespread vasodilation. So there's spinal damage, the blood vessels dilate, there is an absence of sweating because of loss of temperature control. You're not going to see any tachycardia. If you do, it doesn't last very long. So we have looked at septic, we have looked at neurogenic. These are distributive shocks. Let's look at anaphylactic shock now. Anaphylactic shock is a severe allergic reaction. So it's a severe allergic reaction that results in airway complication and circulation issues. So we can get a mild or moderate allergic reaction, and it is not anaphylactic shock because it's not affecting the circulatory system or it's localized. So with anaphylactic shock, an allergen enters the body, and the allergen can be inhaled, it can be ingested, it can be injected, or it can be absorbed. So when it enters, the body cannot recognize it. When something enters the body that it cannot recognize, it will record the structure of this allergen. So it's going to record the structure and then create antibodies and store these antibodies. This is what we call sensitization. During the sensitization phase, you will not see any physical manifestation of an allergic reaction. The body is sensitized and it has prepared itself if this allergen returns. When the allergen returns, it will trigger the antibodies that have been stored, and then we start to get what is called an allergic reaction. Now, when an allergic reaction becomes systemic, that is where it starts to cause problems, because with allergic reactions occurring in the body is going to produce chemicals. And one of the chemicals that are produced is histamine. When the body starts to produce histamine, histamine will cause blood vessels to become more permeable, and it will dilate these blood vessels. So the blood vessels are going to dilate. And if it's a systemic allergic reaction, it means all of the systemic blood vessels are going to be dilated. So that's one. Two, histamine will cause the ear passage to become irritated and constrict. So it irritates the ear passage and cause constriction. So the patient has two significant issues at this time. The blood vessels are too dilated, so the pressure inside the blood vessels drop, which affects the cardiac output. That's distributive shock. And the patient cannot breathe properly. This is what we call anaphylactic shock. When a patient is in anaphylactic shock, giving the patient antihistamine will not fix this problem. So if it's anaphylactic shock, giving them Benadryl or DPH is not going to fix the problem. The patient requires epinephrine. So that is the standard treatment for anaphylactic shock. Epinephrine first. After the epinephrine has been administered, then they can get antihistamine to dry up secretions, not before. So anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure tends to produce a more severe reaction. Now, 4 categories of exposure include injections, tetanus, antitoxin, penicillin, stings, wasps, bees, hornets, ants, ingestion, fish, shellfish, nuts, eggs, medication, inhalation, dust, pollen, mold, and anaphylactic reaction is a reaction that's unpredictable. So it can progress to severity within a few minutes. It's very unpredictable. So this is a patient in which if you recognize in your primary assessment, that this patient may be in anaphylactic shock, you can give the epi after your breathing assessment. So that is acceptable standards because it's a very unpredictable emergency to deal with. So it can develop within minutes or even seconds of contact with a substance. Second phase reaction can occur 1 to 8 hours after the initial reactions. Signs are very distinct. Cyanosis, blue discoloration of the skin, is a late sign. And the anaphylactic shock can cause specific signs and symptoms in various areas of the body, right? They can present with rashes on the skin that itch, hives. They can present with swelling around the eyes. You might not see any facial swelling. The swelling might be occurring inside the airway. They can present with altered mental status, abdominal cramps, nausea, vomiting. So this chart, table 12, 1, 2, pay attention to that. All right, so that's anaphylactic shock. The final distributive shock is going to be psychogenic, which is the easiest one to remember. So psychogenic shock is the same as fainting. It's fainting. Now, what psychogenic shock is, the pathophysiology is, for a brief moment, the blood vessels that supply the brain with blood temporarily dilate. And when the blood flow to the brain is decreased, the patient passes out. So this temporary dilation causes the blood pressure to drop. The brain is not getting enough blood. Patient pass out. As soon as the blood flow returns to the brain, they wake up. That's it. That's psychogenic shock. So it's temporary. What is important for you to try and determine is the position. So what was the position that this patient was in when they lost consciousness? Were they in a bed? Were they standing? Were they walking? Were they on a bus? Were they driving? So where was the patient is important because we need to rule out the possibility of trauma or rule in the possibility of trauma. Also, it is important to find out what happened prior to losing consciousness, if possible. So what occurred prior to? Did the person complain of anything? Person complain of being lightheaded? Did the person complain of their heart feeling funny? Right? So what was the event leading up to the loss of consciousness? That's going to be important. So psychogenic shock caused by a sudden reaction of the nervous system. It produces temporary generalized vascular dilation. It results in fainting, which is syncope. Some causes are serious and others are not. Life-threatening causes include irregular heartbeat, can be a brain aneurysm, which is a weak area in the artery, a weak point in the cerebral artery. Non-life-threatening events include receipt of bad news or experiencing fear or unpleasant sights such as blood. All right, so that's distributive shock. Let's look at hypovolemic shock. And this is where we start to look at the blood volume, which is the blood and the plasma. So it is the result of inadequate amount of fluid or volume in the circulatory system. It can be hemorrhagic and it can be non-hemorrhagic. Non-hemorrhagic occurs with severe thermal burns where intravascular plasma is lost. Now, the blood loss portion is very straightforward. If somebody is bleeding externally or internally from a blood vessel, the pressure inside of that blood vessel is going to deplete, right? Going to be depleted. So the amount of blood that is going to the heart will decrease and the output will also decrease. That's how it results in hypovolemic shock, specifically hemorrhagic. So that's pretty straightforward. The non-hemorrhagic, no. So let's focus on that one a little bit because the bleeding is pretty straightforward. If this is the blood vessel, so this is the blood vessel down here. Let's put some cells inside this blood vessel. So this is a cell. This is another one. This is another. And this is another. One more here and one more here. So that's your blood vessels inside the cell. Now, there is plasma inside. So there's plasma inside the blood vessel, right? Or fluid. So that's plasma. There is plasma within the cells. And majority of the fluid in the body is found inside the cells. So we have fluid inside the cells, fluid in the blood vessels, and we have fluid between the cells. So you have fluid between the cells that is referred to as interstitial fluid. All right, so this is interstitial fluid. Fluid between the cells. Now, the fluid that is inside the blood vessel, so this fluid that is inside the blood vessel is a part of the blood composition. So that's the plasma portion of the blood. If a patient is having excessive diarrhea or vomiting, that plasma portion of the blood is going to be depleted. And if there's depletion, then as I stated before, it's going to affect the amount of blood that's going to the heart and leaving the heart, resulting in shock, because the cardiac output is going to drop. Now, when the plasma inside the blood vessel starts to deplete, this is what is going to happen. If it's excessive diarrhea or vomiting, the fluid that is between the cell will shift into the blood vessel. So that fluid is going to start to shift to fill the space in the blood vessel, right? Start to shift out to fill that space in the blood vessel. Where did that line come from? I have no idea where that line came from. All right, hold on. Let me see if we can get rid of this line. Select. Don't know where this line came from. I didn't create this line. All right. Must have been one of you that did this. Anyway, I can move that now. No, that's the, if I undo, it's gonna undo everything. Anyway, continuing. So the fluid starts to shift. Go back to my pencil. The fluid starts to shift out and fill the space inside the blood vessel. So when the fluid that is between the cells start to shift from their normal position, the fluid that is inside the cell will start to shift to fill the space that's between the cells. And what is going to happen as the fluid starts to shift outside of the cell? So as the fluid starts to shift out, the cell is going to shrink. So the cell is going to shrink in size and become dehydrated. That's dehydration or apoptosis, right? So the cell is going to shrink. So the patient can develop dehydration with the hypovolemic shock. And that's going to be for plasma loss via excessive vomiting and diarrhea. With burns, it's a little different. Plasma is being lost with burns, but the movement of fluid is different. With the vomiting and diarrhea, eventually the cell becomes dehydrated. And when we say a cell is dehydrated, we mean it shrinks in size. It doesn't function properly because when it shrinks, it don't have the electrolytes that it needs inside of it. With burns, basically what happens, so this is a blood vessel, and these are this blood vessel is the capillary, right? So this is the capillaries. You have your cells inside the capillaries, right? And outside of the capillaries, you have your tissue cells. So you have tissue cells outside of the capillaries. Now, what happens with burns is when the patient has severe burns, it damages the capillaries and they start to leak fluid, right? So they start to leak out fluid, and that fluid starts to leak into the cells, the tissue cells, right? So the plasma starts to leak into the tissue cells. So there is a depletion of volume in the blood vessel because the plasma is leaking out of the blood vessel, and it eventually ends up inside the cell. Now what is going to happen to the cell is the cell is going to swell up, and eventually it will rupture. So it's going to burst, right? Going to swell up and rupture. We call that hemolysis. So the plasma, when it's severe burns, the cell swell up and burst. When it's severe vomiting and diarrhea, eventually the cell is going to be depleted of fluid and it shrinks. That's that. All right, moving forward. So dehydration, the loss of water or fluid from body tissues, can cause or aggravate shock. Fluid loss may be a result of severe vomiting and or diarrhea. Now, respiratory insufficiency. So that's the 4 types of distributive shock. Respiratory insufficiency, a patient with severe chest injury may be unable to breathe in an adequate amount of oxygen. An insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. So all this slide is saying that if the respiratory system is compromised, it can cause similar complications from circular issues that lead to shock. So breathing problems, severe breathing problems can cause a shock state in your patient. Anemia is an abnormally low number of red blood cells. Hypoxia occurs because blood is unable to deliver adequate amounts of oxygen to the tissues. Certain types of poisoning may affect the ability of cells to metabolize or carry oxygen. So carbon monoxide poisoning, when carbon monoxide is in the body, the body has a higher affinity for carbon monoxide, not carbon dioxide. The body has a higher affinity for carbon monoxide than oxygen. I think it's 250 times in comparison. So when carbon monoxide is in the body, if carbon monoxide is in the body and oxygen is in the body, the red blood cell is going to bind to the carbon monoxide more than the oxygen. It loves that more than oxygen. When that occurs, then the red blood cell cannot be oxygenated. So it can cause significant desaturation within the body, and it can lead to death. Not a painful death. So a lot of persons will use this method to commit suicide. Cyanide poisoning affects the ability of the red blood cell to bind to the oxygen, right? So it will interfere with the ability of the red blood cell to bind to the oxygen. Unlike carbon monoxide, it's quite painful. Cyanide was what Jim Jones used to kill the people in Guyana, almost 1,000 people in Ghana. Right, so it's cyanide poisoning. All right, now the progression of shock. The stages in the progression of shock. So you have the compensated stage of shock, and this is the early stage when the body can still compensate for blood loss. So everything tends to go up in this stage, and usually the blood pressure is not low at this point. The decompensated stage of shock is the late sign or late stage, and this is where the blood pressure starts to fall. And when blood pressure starts to fall in the body, you start to lose your peripheral pulses. If the peripheral pulses are present at this stage, they're going to feel extremely weak and thready. No way to assess when effects are irreversible, and usually when a patient reaches irreversible shock, is only the mercy of God going to save him or her at this point. So the goal is to recognize early that the patient is exhibiting signs and symptoms of shock and do what you need to do. So you must recognize and treat shock early. The blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is well developed, particularly true in infants and children. Expect shock in many emergency medical situations. Also expect shock if a patient has any one of the following conditions: multiple severe fractures, abdominal or chest injury, spinal injury, severe infection, major heart attack, anaphylaxis. Now the patient assessment approach. And you're going to see patient assessment, airway management, and shock, and anatomy and physiology in every emergency that we cover from this point on. Hence why they are the core chapters of this course. So the patient assessment, you ensure that the scene is safe for you and your crew members. Take the appropriate standard precautions. Identify the mechanism of injury or nature of illness. How many patients you have, whether or not additional resources are required, and based on a significant MOI, you might want to consider the possibility of spinal complications. So be alert to potential hazards to your safety. Use gloves and eye protection for trauma scenes or if bleeding is suspected. In incidents involving violence, make sure police are on scene. In your primary assessment, and the purpose of your primary assessment is to identify and manage immediate and potential life threats. So your primary assessment, perform a rapid exam, determine the level of consciousness, identify and manage life-threatening concerns, determine the priority of the patient and transport. So in your primary, form a general impression of the patient and the environment. You're going to ascertain the patient's level of consciousness. You're going to assess and manage the patient's upper airway. You're going to assess and manage the patient's lower airway. And your assessment of the upper airway, if it's compromised, is position, make sure it's clear, look, listen, feel, check for a pulse if the patient is not talking to you. The assessment of the lower airway is you check the rate, rhythm, quality, and depth. Based on that assessment, you will determine if you need to give supplemental high or low flow, or you need to provide positive pressure ventilation for the patient. After you have completed your AB, next is C, circulation. Quickly expose if necessary to see if the patient is bleeding from anywhere. Bleeding observe, control bleeding. Then evaluate the pulse. If the patient is talking to you, peripheral pulse. If they are not talking to you, central pulse. And we want the rate, rhythm, and strength of that pulse. Then we look at the color of the patient's skin in the palms. If we see abnormal changes, we look for it centrally. We check the temperature of the skin, hydration, cap refill, that's the ABCs. Once ABCs are completed, we should know the GCS of the patient. We should know if we need to do a rapid scan or focus, and we should know if this is a load and go or stay and play patient. To provide high flow oxygen to assist in perfusion. For hypoperfusion, treat aggressively and provide rapid transport. Request advanced life support as necessary. Form your general impression, assess airway to ensure it is patent, assess breathing. An increased respiratory rate is often an early sign of impending shock. Assess the patient's circulatory status. A rapid pulse suggests compensated shock. In shock or compensated shock, the skin may be cool, clammy, or ashen. Assess for and identify any life-threatening bleeding and treat it at once. Determine if the patient is high priority, if ALS is needed, and which facility to transport to. Trauma patients with shock or a suspicious MOI generally should go to a trauma center. I have 4 levels of trauma centers in the States. And a trauma center doesn't mean that it only deals with trauma, right? So it doesn't mean that it's only trauma patients they will be treating. A level 1 trauma center has every specialty that a patient will require. The difference, actually, the level 1 and level 2 trauma center has every specialty that the patient would require. The difference between a level 1 and a level 2 trauma center is a level 1 trauma center is a teaching hospital. The level 3 trauma center has specialties, but they are on call. So they have to request that doctor to come in that specialize in whatever area. They are not at the hospital. And a level 4 hospital can only provide ALS treatment. Now, outside of trauma centers, you have special care centers, you have burn centers, you have pediatric centers, you have cardiac patient centers, you have, what's the other one? Slipping me now. You have OB that specialize in obstetrics, centers that specialize in that. Now in Jamaica, it's where our classification is different. We don't have the trauma classification in Jamaica. I think it's level A, B, and C, and level A is I would be the equivalent of a trauma 1 center, but I'm not sure if that's the case because the top hospitals in Jamaica don't have all the specialties at the hospital. So I don't know, but level A would be the classification for, I believe, for UE and KPH. Not sure about the other hospitals. All right, now the history taking phase. During this phase, after we have completed the ABC assessment and we have made a decision regarding the patient's GCS, whether or not we need to do a rapid scan or a focus, whether or not it's a load and go patient, if we prepare the patient for transport, patient is talking to us, then we need to get information. So we need to determine patient's chief complaint, we need to obtain history on the presenting problem, and we need to obtain a sample history. This information can be obtained directly from the patient, family members, or it can be taken from bystanders, or you can look at the scene and look at the patient for clues. The patient or family members and bystanders cannot tell you exactly what's going on. Pay close attention to your patient. So look at the patient, see what's going on with your patient, hands-on, and ensure that you include pulse oximetry, pupil reaction, and DMR reading in your vital signs. Secondary assessment comes after the history, and this is necessary it is necessary because we may have been focusing heavily on the primary assessment, so we might miss certain things. So it is done to pick up things that may have been overlooked and to pick up things that develop slowly. And it is this phase of the assessment that we are going to do our baseline recorded vitals, and we are going to compare it to what the patient presentation was prior to treatment. So the baseline vital signs give you an idea of how the patient is responding to your treatment. The initial checks that you do in your primary is going to give you the baseline in terms of whether your patient is in serious trouble or not. So by comparing, you will know if your patient is getting better or worse. So your secondary assessment begins by repeating the primary assessment, followed by a focus assessment. If a life-threatening problem is found, treat it immediately. Obtain and complete a set of baseline vital signs. We want pupil reaction. We want respiration with pulse oximetry. And if available, end-tidal CO2. We want the pulse, right? So we want a pulse. We want GMR. We want blood pressure. Right, so these are your vital signs that you want. After we have completed the secondary assessment, then the next phase is the reassessment. You're repeating the primary, looking at your interventions, you're checking to see what has changed. Has it gotten better or worse? Do you need to make any adjustments? During this phase, you will also be radioing you'll be calling into the receiving facility to give your report, and you will be documenting as well. And for documentation, it is chronological method, SOAP or chart. For your radio report, it's what the patient tell you, what you observe, what you did based on observation, how the patient responded, and method of transportation. So reassess the patient's vital signs, interventions, chief complaint, ABCs, mental status. Determine what interventions are needed. Focus on supporting the cardiovascular system. Treat for shock early and aggressively by providing oxygen and keeping the patient warm. I do strongly believe that EMTs need to learn how to do fluid resuscitation, EMTs, especially in Jamaica, based on the type of trauma injuries that occur here. I think that's important. But we can have a discussion about that later on. I will teach you how to do it, but it will be up to your organization to decide if they will allow you. So you need to have an idea of how to do an IV access and administer fluid to a patient who is in hypovolemic shock. Penetrating trauma is very common in Jamaica. Motor vehicle accidents is very common in Jamaica. And a lot of these patients are not making it because of fluid deficit. All right. Emergency medical care for shock. As soon as you recognize shock, begin treatment. Follow standard precautions. Control all obvious bleeding. Make sure the patient has an open airway. Maintain manual inline stabilization if necessary. Check breathing, check pulse. Comfort, calm, and reassure the patient. Never allow the patient to eat or drink anything prior to being evaluated by a physician, because less blood is going to the intestine. At that point, they are at risk for vomiting. And if they are going to require surgery, they can't have anything in the stomach. If spinal immobilization is indicated, splint the patient on a backboard. I will show you how to perform spinal immobilization, but you also need to be familiar with spinal motion restriction. So what is really being done now is spinal motion restriction, but the curriculum has not been updated to reflect that. Provide oxygen and monitor the patient's breathing. Place blankets under and over the patient. Consider the need for ALS. Do not give the patient anything by mouth, no matter how urgently you are asked. Accurately record the patient's vital signs approximately every 5 minutes throughout treatment and transport. Now let's look at treating the specific shocks. Now for Cardiogenic shock, the patient cannot generate power to pump blood throughout the circulatory system. Chronic lung disease can aggravate cardiogenic shock. Patients in cardiogenic shock should not receive nitroglycerin, which is a vasodilator, if they are hypotensive. So there are some patients who have a history of angina, which is chest pain. They will be on nitroglycerin. And the indication for nitroglycerin or presentation of angina is going to be similar to a heart attack. So sometimes they will take the nitroglycerin when they start to get that chest pain. If the nitroglycerin doesn't work, it means they might be having a heart attack. If you come and your blood pressure is low, then they can't take any more of that nitroglycerin. It's a vasodilator. Patients usually have low blood pressure, weak irregular pulse, cyanosis about the lips, underneath the fingernails, anxiety, nausea. Place the patient in a position that eases breathing as you give high flow oxygen. Be careful with your use of sirens for these patients. They can trigger arrhythmias or dysrhythmias. Assist ventilation as necessary. Provide prompt transport. Consider meeting ALS en route to the hospital. Provide calm reassurance to a patient with a suspected heart attack. And for what? My slide froze a bit. We backtrack. Okay, good. For cardiac tamponade, which is a form of obstructive shock, increasing cardiac output is the priority. Apply high flow oxygen. Surgery is the only definitive treatment. The patient is going to require pericardiocentesis, which they're basically going to use a needle to pull the fluid out of the pericardial sac. It is an advanced skill, but it is rarely performed in the field. So I was taught how to do it as a paramedic. But I would never attempt that in the field, right? You were taught the procedure, but that's not something I'm going to do in the field. Definitely not. For tension pneumothorax, apply high flow oxygen to prevent hypoxia. Chest decompression is required. Ask for ALS early in the call if available, but do not delay transport. So don't wait unseen for ALS to arrive. If you package your patient and you're ready to go, let ALS meet you at a point. You can't wait too long with these patients. The paramedics are allowed to do this procedure in the field, right? So it will give the patient a lifeline for sure. Treating septic shock. Hospital management is required. Use standard precautions and transport. Administer high flow oxygen. Ventilatory support may be necessary. Use blankets to conserve body heat. Use a sepsis team if available. Oops. Let me back up a bit. Okay. Treating neurogenic shock. For the spinal cord injury patient, use a combination of all known supportive measures. Hospitalization will be required for a long time. Why is my slides all of a sudden freezing? There we go. That should be better now. Right, much better. Let us continue. Let me backtrack a bit. Okay. Sorry about that. Had a little connection issue. Right, now emergency treatment. Obtain and maintain a proper airway. Provide spinal immobilization or spinal motion restriction. Assist inadequate breathing. Conserve body heat. Ensure the most effective circulation. Transport promptly. In treating anaphylactic shock, epinephrine, administer epinephrine, promptly transport the patient, provide high flow oxygen and ventilatory assistance en route. A mild reaction may worsen suddenly. Consider requesting ALS backup if available. Treating psychogenic shock in an uncomplicated case of fainting. Once the patient collapses, circulation to the brain is restored. Psychogenic shock can worsen other types of shock. If the patient falls, check for injuries. If the patient reports being unable to walk after a fall, suspect another problem, transport the patient promptly, record all initial observations, and try to learn from bystanders. If the patient complained of anything, how long the patient was unconscious, these are important questions to ask and get answered. Treating hypovolemic shock, control all obvious external bleeding. Keep the patient warm, recognize internal bleeding, and provide aggressive support. Secure and maintain an airway and provide respiratory support. Transport as rapidly as possible. In treating respiratory insufficiency, secure and maintain the airway, clear the mouth and throat of obstructions. If necessary, provide ventilations with a BVM, administer supplemental oxygen, transport the patient promptly. Now, in treating shock in the geriatric population, the EMT must use caution when caring for older patients. Older patients have more serious complications in comparison to younger patients. The illness is not just a part of aging. Many older patients are on medications that can either mask or mimic the signs and symptoms of shock. And that would bring us to the end of the shock chapter. Let me